Mr. Lamborn, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Lynch, in the last 2 weeks, the number of veterans in my district in Colorado Springs that contacted my office asking for help while trying to see a doctor has more than doubled. One veteran described how he was referred to get a biopsy done on his thyroid to determine whether or not he had cancer, only to be told he couldn't be seen for 2 months. I can't imagine having to wait for 2 months to even just get a test done when you have a possible cancerous growth. Tell me what options, please, are available to the Denver VA Medical Center to expedite a biopsy appointment in particular, especially based on medical necessity and if there's the possibility of a life-threatening condition.
Congressman, based on what you're telling me, if services cannot be provided in less than 30 days, that is an unacceptable waiting time. And the Denver VA facility should be able to identify a community provider to offer those services.
And that would be the fee-basis approach that we've talked about.
That would be the use of non-VA care or the fee-basis approach, yes.
Okay. So 55 days for that type of procedure is unacceptable, you would agree?
That would certainly be my impression, Congressman.
All right, thank you. Now, the data included in the VA's bi-monthly access data update makes me worry that this problem might be getting worse before it gets better, especially in Colorado. And myself and Representative Mike Kaufman have a lot of these same concerns. Although the report showed the number of veterans on the electronic wait list across the country dropping slightly, the electronic wait list at the Denver VA Medical Center, where many of my constituents receive care, doubled in the last 15 days. It went from 1,632 to 3,331. What could have caused that number to double in 15 days when around the country it was dropping slightly?
I don't have the specifics on Denver, Congressman. I will be happy to try and get that information for you. I can tell you that at the moment, the electronic wait list is going to be dynamic. There are two processes that are occurring. We are working down the near list, the new enrollee appointment request. Those patients are either being given scheduled appointments or they are being put on the electronic wait list. So it's possible that some of the patients that were on the near list have been moved to the electronic wait list. But exactly, why they are accumulating on the electronic wait list, I don't know, but I think we have the capacity to find that out.
Okay, well, if you could get back to me on that, I would appreciate it.
I will do that, Congressman.
Okay, thank you. Now, you stated in your written statement that the average current number of patients assigned to each primary care provider is 1,194. How does that compare with the private sector?
The private sector medical home model can vary with panels of anywhere from 1,000 up to about 2,000. It depends on the complexity of those patients. It depends on the resources available and the support for the physician seeing those patients. VA patients are often older. Patients in the private sector may be younger, healthier, and may not require the intensity of care that VA patients require. Dr. Clancy, would you have any comment?
No. Sorry. I would agree with all of that. We also, the VA's medical home in the primary care setting is also unique for being integrated in many of our facilities with mental health providers who are right there if those needs arise.
Okay, thank you. One last question I want to get in. You note in your written testimony that the VA is adopting productivity standards that are modeled on industry-accepted standards. I'm really glad to hear that, but what's been the case, what's been the standard up until now?
Sadly, Congressman, there hasn't been a standard to this point. We are now using the relative value unit to evaluate the productivity of our providers. We're then using that information to determine, number one, are they meeting minimum productivity standards? Number two, if they are not, why not? It could be a matter of support and available resources. It could be a matter that there are not enough patients for them to see. And in that case, either we need to identify more patients, or we need to figure out a way that we can move their capacity to another facility, perhaps using something like telehealth.
Thank you.